There are a lot of disorders that can be discussed under this major discussion of the geriatric psychiatry that we're dealing today. Among the different conditions that are prevalent in this age group, also ranging from the mood affective disorders, the bipolar illnesses, the split personalities, it can be the very late onset schizophrenia, also abbreviated as VLOS. So it's quite prevalent in this age group over 65 years of age. So again, it can be an early onset schizophrenia that changes into this late onset schizophrenia. On the other hand, we have the other age groups in which the person was quite normal in his in his adolescent, when the child history was searched for the psychiatric illnesses. He was not suffering from any sort of psychiatric illness, but still he developed schizophrenia in his later age group, that is over 65 years of age. So people usually suffering from the OCDs, that is the obsessive compulsive disorders, they usually come up with this complaints of hallucinations, or which can range from the visual, the tactile, or the auditory hallucinations, and usually these people are diagnosed with schizophrenia. So what are the risk factors that make the person more prone to development of this very late onset schizophrenia? We'll be discussing them over here. It can range from the environmental factors as well as the personality traits of the person. So even if the person was mental illness free, still he can have those personality traits which make him more prone to the development of such a disease. So even if he was the type A personality, having those obsessive or those compulsive symptoms at earliest, then he may be more prone to the development of such states such as schizophrenia. So dealing with these patients can sometimes be quite interesting. How do we go about to manage such cases will be discussed over here. The etiology, the causative factors will be discussed, and along with that, the clinical presentations, that is basically the basic manifestations are the thought form, the thought content. We have the paranoid delusions, we have the delusions of persecutory, that is quite commonly seen in these individuals. Then the treatment guidelines, how do we go about and involve the healthcare facilities along with them to help these people come out of these difficult situations, is again very important and very significant. So we'll be discussing this condition over here in this very third section. The paraphrenia, or very late onset schizophrenia. So these are the terminologies that are quite commonly used. On one hand, we can call it a delusional disorder. In other phases, we can call it a paraphrenia or the late onset schizophrenia. There are 35,000 people altogether that are affected by this VLOS. Psychotic symptoms are underrated in these individuals. They're usually socially isolated and suspicious. The female to male ratio, when we weigh this, it's basically 3:1 to 20:1. So this is quite a prevalent disease in the females. So we have to basically screen out. We have a lot of screening tests devised for this screening phenomena. The social isolation, then if the person was suffering from some sort of psychotic illnesses such as OCD, anxiety disorders, panic disorders, he was a type A personality, all of these make him more prone to the development of the VLOS or the very late onset schizophrenia. So the prevalence is quite underrated, but according to the researches that have been carried out, it's quite a prevalent disease in the old age group. Talking about the etiology, it's quite unclear. So there are multiple factors that are involved in this schizophrenia. First of all, we are going to discuss the external stressors that can lead to the development of such late onset schizophrenia. We have the environmental factors, the social isolation, the presence of the primary caregivers, if the death of a loved one takes place. All of these are the stressors of the life that takes place in the later age group, that is over 65 years of age. Then we have the empty nest syndromes. All of these phenomena are the late life stressors. They are basically making the person more prone to the development of a lot of psychiatric illnesses, and one of them is this schizophrenia. So the internal structural damage is also seen in these individuals upon imaging techniques. For example, CT scans and MRIs, when they're carried out, we have a lot of findings in such brains who are suffering from the schizophrenia, or they have the delusional paranoias along with them. The predispositions and the personal traits, again, the personality traits would be assessed. First of all, a lot of questionnaire techniques can be applied to this. The predispositions, getting the childhood history, getting the adolescent history is again very important over here. So the schizoid and the personality traits will be discussed when we are taking the history, when we're documenting the history in detail, when we are taking the collateral history from the close relatives and the family. So the sensory impairment can be seen in these individuals. For example, dementia is one of them, and then social isolation and deafness, or the hearing impairment. All of these can basically contribute to the development of the schizophrenia, or the very late onset schizophrenia in these old people. The clinical presentation, usually it is similar to the early onset schizophrenia. It is basically usually when we look at the personalities of these individuals, they are preserved or isolated or unsocial personalities that are more prone to the development of such schizophrenia. If we look at this pie chart, we see that the over-methylated version is the most common version over here, that is basically contributing towards the development of schizophrenia. That makes almost 45% of the population. Good pre-morbid personalities of a psychosocial function, and then we can have the good educational and occupational history. So all of these are basically findings of the different researches that have been carried out, and they basically contribute towards the development of such clinical presentations. Delusions and hallucinations, they are quite commonly seen. Now, when we talk about the delusions, they can be the delusions of persecutions, delusions of paranoia, and then there's a very interesting phenomena known as partition delusions, which is seen in these individuals, in which the person gets basically conspicuous about his or her neighbors, that they're basically making a conspiracy against that person. So these are known as the partition delusions, and they're quite commonly seen in these individuals. And then we have the hallucinations that can range from the tactile hallucinations to the visual as well as the auditory hallucinations over here. So the persecutory delusions are quite common. Partition delusions, in which the person basically feels unsafe from his neighbors. They are also quite commonly seen in these individuals. Auditory hallucinations are quite common. And then we have the impacts on the neighbors and the families. So the close friends, the relatives are going to be impacted through these thought form and thought contents. Talking about the treatment guidelines, when we are dealing with a person suffering from schizophrenia, the patient often refuses medication because he doesn't have insight towards his condition. They have little insight, and the antipsychotic medications are usually prescribed. Behavioral therapies are coupled along with them. Establish the therapeutic alliance is very important in a community as well as to the nursing colleagues. So over here in this section, basically we summarize this condition, which is known as the very late onset schizophrenia. What are the etiological factors, the causative factors, and the treatment guidelines for such condition in the geriatric psychiatry. So that is the end of this section. Thank you for watching sqadia.com.